Welcome to the ISTH webinar series. I am Amy Shapiro, pediatric hematologist and medical director at the Indiana Hemophilia and Thrombosis Center in Indianapolis. This webinar series is hosted by ISTH, and we thank them for this opportunity. Today, Dr. Stacy Croteau, Emily Bisson, and I will be discussing rebalancing therapies for hemophilia. Are you ready? You can scan the QR code to learn more about this activity. These are the learning objectives for today's webinar. We will assess how emerging rebalancing treatments impact the individualization of treatment for patients with hemophilia, compare the clinical profiles of emerging rebalancing therapies for hemophilia, and outline strategies for preparing treatment teams and centers for emerging rebalancing therapies in hemophilia. The first question is, which of the following is a potentially unique benefit of rebalancing therapies for patients with hemophilia? Is it application for patients with hemophilia A or B, weight-based dosing, amelioration of joint damage, or use in pediatric patients less than or equal to 12 years of age? The next question is, marstacimab and concizumab directly target which of the following anticoagulant proteins? Activated protein C, antithrombin, factor 11A, or tissue factor pathway inhibitor, TFPI. And our last question is, what is the key consideration when transitioning patients from factor replacement to rebalancing therapies? Cessation of all other hemophilia treatments, establishing appropriate washout periods, increasing the dose of factor concentrates, or switching to on-demand treatment only. Let's review how we treat now and in the future. Over the last few decades, major innovations in hemophilia treatment have been achieved and continue to progress at a rapid pace. Replacement therapies and treatment regimens have evolved along parallel lines, including advancements in each area. Therapy has moved from treatment of bleeding episodes once they have occurred, termed on-demand or episodic therapy, to an understanding that bleed prevention or prophylaxis represents optimal care. Therapeutics have advanced from plasma fractionation to development of recombinant technology, increasing safety and production capacity. Through bioengineering, extended half-life products have been developed, which provide longer intervals of hemostatic levels. Treatment evolution also includes development of factor VIII mimetics, rebalancing agents, and gene therapies. The first approved factor VIII mimetic was emicizumab, available for treatment of factor VIII deficiency with and without an inhibitor. This mimetic is a humanized, bispecific monoclonal antibody that substitutes for the scaffold effect of factor VIIIa and is administered subcutaneously with a flexible dosing schedule and a long half-life. Emicizumab has significantly reduced treatment burden, most notably in factor VIII inhibitor patients and those with difficult venous access. Next-generation factor VIII mimetics are in development and include Mimate and NXT007, both of which are in clinical trials. Mimate has a reported 15-fold increased potency as compared to emicizumab analog, allowing for a reported 15-fold a lower dosing volume, while NXT007, a second-generation emicizumab, is predicted to be 30 times more potent than emicizumab. Other bispecific and monoclonal antibodies are in differing stages of clinical trials for a variety of bleeding disorders. Novel agents that downregulate naturally occurring inhibitors of coagulation are capable of rebalancing hemostasis to treat bleeding disorders. Recently, 2 such agents have become clinically available, both of which target the Kunitz-2 domain of TFPI, but with different target affinity, dosing regimens, and approved indications. Further rebalancing agents are progressing in clinical development, including a small interfering RNA targeting antithrombin for hemophilia, and an antibody targeting protein S for von Willebrand disease with potential applications to hemophilia. These non-factor therapies are administered subcutaneously for prophylaxis. They do not treat an acute bleeding event. Dr. Croteau will discuss these agents in more detail later in this presentation. Gene therapies delivered via hepatotrophic vectors have been approved for hemophilia A and B. In addition, gene editing technologies and cellular therapies continue in clinical trials. Providers can now individualize prophylactic regimens targeting desired goals for treatment, including type of product, such as an infusion therapy versus a novel agent, degree of protection required, and route and frequency of administration. These patient-specific regimens support improved outcomes while focusing on patient health needs and life goals, which are often impeded by a spectrum of issues. Yet challenges remain, including the presence of chronic pain due to joint damage and intercurrent bleeding episodes, both of which lead to activity limitations and create psychological and physical burden. There is also the burden of intravenous dosing for administration of factor replacement therapies, which may necessitate a central venous catheter in young patients or in older individuals with limited upper extremity mobility or poor venous access. These therapies require adherence to an established regimen, which may be difficult or interfere with daily life. Patients with inhibitors remain a vulnerable population. Approximately 35% of individuals with severe factor VIII deficiency and between 5 to 10% of severe factor IX deficiency develop inhibitory antibodies that interfere with standard replacement therapy. Although factor VIII mimetics have provided adequate prophylaxis for most factor VIII deficient patients with inhibitors, there remain breakthrough bleeding episodes which interrupt life and require intravenous treatment. Overall, patients with inhibitors are more fragile and face more frequent bleeding events and their sequelae, especially factor IX deficient patients with inhibitors. This graphic illustrates the pharmacokinetics of standard and extended half-life replacement therapies with peaks and troughs and estimated time within the ideal or therapeutic range. Non-factor therapies, such as mimetics or rebalancing agents, do not change the underlying deficiency state, as illustrated by the flat line under the factor level at the bottom in the middle section. Yet these agents provide hemostasis through alternative mechanisms and confer a steady state level for hemostasis without peaks and troughs. Emicizumab confers an estimated factor VIII equivalence of approximately 10 to 25% without changing the underlying factor VIII activity. But it is important to note that if you measure the factor VIII through standard assays, while in emicizumab, you get a falsely elevated factor VIII level. In non-inhibitor patients, gene therapy raises your underlying factor VIII or IX activity, hopefully to a level within the ideal prophylactic range, and at times to near normal levels. Prophylactic agents that target naturally occurring inhibitors of coagulation require a delicate balance between adequate bleed control without excessive inhibition that may lead to some thrombosis. So the question is, can we get the balance right? The normal hemostatic system is a finely tuned, complex mechanism that balances procoagulants and naturally occurring inhibitors of coagulation. This delicate balance permits an appropriate response to hemostatic challenges to allow bleed cessation while also downregulating thrombin generation to limit coagulation to areas of insult or injury without excessive clot propagation. When a procoagulant is deficient, as in hemophilia, the balance is tipped towards excessive bleeding. Whereas when a naturally occurring inhibitor of coagulation is deficient, the balance is tipped towards excessive clotting or thrombosis. When both a procoagulant is deficient and a naturally occurring inhibitor is downregulated, hemostatic balance may be restored based upon the level of each. This graphic depicts the targets of rebalancing agents. Through these myriad innovations, it is hopefully possible to prevent bleeding episodes and the consequences of these events, including target joints, with anticipated improvement in joint health, which ultimately will translate to a higher quality of life. In summary, patients on factor replacement prophylaxis may experience a variety of unmet needs based upon their treatment product and regimen. Patients with inhibitors experience more disease sequelae, especially those with factor IX with inhibitors who until recently had no approved prophylactic therapy. Rebalancing therapies enhance hemostasis by reducing or downregulating the natural inhibitors of coagulation. Our next presenter is Dr. Stacy Croteau. Dr. Croteau is the medical director of the Boston Bleeding Disorders Clinic, assistant professor of pediatrics, Harvard Medical School, Boston Children's Hospital in Boston, Massachusetts. As a reminder, we will address all questions after the talks have concluded. Dr. Croteau will be discussing the what and the why.
Thank you so much, Dr. Shapiro. Now it's time for the what and the why. So let's dig in a little bit further. So as you heard in the first section, Dr. Shapiro highlighted a number of non-factor replacement therapies, including a number of different rebalancing therapies that are or have been in investigation. In the next few minutes, we're going to hone in a bit more on the three therapies that are the furthest in development. The first two in the anti-TFPI monoclonal antibody category, marstacimab and concizumab, have achieved FDA and EMA approval. The final one, antithrombin siRNA fitusiran, is still finished a phase 3 trial and is still awaiting decision-making by regulatory bodies. So marstacimab and concizumab, as I mentioned, both in the anti-TFPI category. The dosing regimen differs, though these therapies are quite similar, with marstacimab being administered subcutaneously weekly with a fixed dose for individuals 12 and older, while concizumab is administered also subcutaneously but daily. And this is a weight-based dosing strategy and also requires adjustment based on concizumab plasma concentration levels after the first 4 weeks of treatment. Both of these products were approved just within the last year, as I mentioned, both by the FDA and EMA. Interestingly, again, though the mechanisms of action of both of these medications are very similar, marstacimab has first received approval for prophylaxis in individuals greater than or equal to 12 years of age with either hemophilia A or B without inhibitors with intent for prophylactic use. While concizumab was approved in the same age group, greater than or equal to 12 years of age, also, of course, can be used for hemophilia A or B, but for this particular medication, for those individuals with inhibitors. All three of these medications have been undergoing clinical trials, both in inhibitor and non-inhibitor populations in both the adolescent, adult, and pediatric populations. However, the data maturity for marstacimab and concizumab have not reached final approval for additional hemophilia subtypes with or without inhibitors for younger children. Similarly, with fitusiran, we haven't seen the regulatory authority commentary on this product yet. Presumably would similarly first be approved if it is approved in the 12 and older adolescent adult population. But the approvals with inhibitors, non-inhibitors remain to be seen based on the data presented. As we focus a bit more on marstacimab, looking at the phase 3 pivotal trial, this was the BASIS trial. This initial trial design looked at individuals 12 to 75 years of age, and this is the non-inhibitor cohort, so it included 116 patients. First, individuals were observed for a 6-month period, and they were observed in one of two groups, either on routine prophylaxis, to which they came to the study, or in an on-demand factor replacement therapy group, if that is how they first came to the study. Following these months of observation, they were then initiated on a 12-month active treatment period with marstacimab. This was dosed, as has subsequently been labeled, with a loading dose of 300 milligrams subcutaneously followed by weekly 150 milligram subcutaneously injections, and as mentioned, with the indication for prophylaxis. The primary outcome measures that were investigated as part of the BASIS trial included the annualized bleed rate, or ABR, for treated bleeds, as well as the incidence and severity of thrombotic events, anti-drug antibodies, and clinically significant persistent neutralizing antibodies against marstacimab. And of course, the incidence of adverse events and other serious events were recorded as well. While the phase 3 study has come to its initial primary endpoint conclusion, additional studies continue, as mentioned previously, including the long-term follow-up study looking at persistent use of once-weekly marstacimab in the non-inhibitor cohort. There is also a BASIS Kids study, which is investigating those under the age of 18, again with severe or moderately severe hemophilia A, B, with or without inhibitors. And there is also a study looking at changing of therapy from another non-factor replacement therapy, emicizumab, to marstacimab in that adolescent to adult age group. When we look at the ABR rates, so the annualized bleeding rates for treated bleeds for marstacimab in the hemophilia A or B without population without inhibitors, what we can appreciate is that during the routine prophylaxis period, the model-based estimated ABR was around 7.9 for this group, included 83 patients. When they looked at the ABR while on the active treatment phase of marstacimab, so within the first 12 months, the ABR decreased to 5.1. And then when they pulled data from the long-term outcome study that looked further than the 12 months, they saw ongoing decrease in the annualized ABR at 2.8. So overall demonstrating a significant difference, both statistically and clinically, in ABR in patients treated with marstacimab relative to their prior routine factor prophylaxis. When we think about safety with marstacimab, this table highlights the adverse reactions that were reported in at least 3% of patients treated with marstacimab. And you'll see, fortunately, this list is quite short. As is common with many of the subcutaneous therapies that we have become used to, injection site reactions seem to always be amongst the highest frequency of adverse reactions observed. In this particular cohort, we also saw headache and pruritus meet this criteria of greater than 3%. So in general, marstacimab was safe, well tolerated in patients with hemophilia in pivotal studies and in the long-term extension studies. And there were no evidence of thrombotic events during these clinical trials. You'll note, though, that there's a number of elements that I haven't mentioned, and we'll hopefully highlight these a bit later in the case. What happens for individuals when we have a significant traumatic event or a significant acute inflammatory illness, or we have an individual that needs to go for a major surgery. Many of these clinical scenarios were not captured, as is typical, as part of the clinical trials, and leaves a bit of gap of knowledge at the moment that we need to adapt to as clinicians as we're developing our workflow strategies. As we move on to concizumab, the pivotal phase 3 study for this medication was the Explorer-7 study. Similar to the marstacimab study that I previously mentioned, this phase 3 study included hemophilia A and B patients aged 12 to 84 years of age. And for this cohort, they all included inhibitors and had a total of 133 patients. The overall study design is somewhat similar, where here they had a 32-week observation period where individuals coming into the study either continued on their routine prophylaxis or on their on-demand replacement strategy, if that's what they came to the study as is their baseline regimen. This was followed by a 256-week active treatment period using once daily subcutaneous concizumab prophylaxis. Concizumab was also administered first with a loading dose of 1 milligram per kilogram on day 1, followed by subsequent daily dosing of 0.2 milligrams per kilogram. Following the first 4 weeks of using this regimen, concizumab plasma concentrations were identified, and then the dose modified based on those results. The primary outcome measures included the ABR for patients with hemophilia A or B with inhibitors, with or without target joints at baseline. So this table helps us summarize the ABRs for treated bleeds for those on concizumab, the hemophilia A and B population together with inhibitors. And you'll notice that it's broken down into two sub-cohorts. The first column, those with target joints at baseline, and the second without target joints at baseline. And also looks at the individuals that received an on-demand regimen versus the concizumab prophylaxis. So for those with target joints at baseline, there were 10 included here that started with an on-demand strategy, and you can see the estimated mean ABR of around 10, compared to concizumab prophylaxis, for which the estimated ABR decreased to 1.7. You can also see the confidence intervals there, the 84% reduction, and of course, meeting both statistical and clinical significance, and the mean weeks of exposures noted below. For those without target joints at baseline, using an on-demand strategy, the ABR was around 9, decreasing on concizumab prophylaxis to 0.9, with an overall 90% reduction, as you can see, both statistical as well as clinical significance. So there is a significant difference in the ABRs for patients that were treated with concizumab for prophylaxis relative to on-demand therapy. When we look at the safety considerations for concizumab, in this particular case, they've reported adverse reactions as those reported in greater than equal to 5% of patients with inhibitors treated with concizumab. And of course, topping the list again, injection site reactions with a secondary adverse frequency of pruritus. It is also notable that while happening in less than 5% of participants in the clinical trial program for concizumab, to note that we did have thrombotic events. So the concizumab clinical trial program was paused in 2020 due to 3 non-fatal thromboembolic events in participants who were receiving concizumab. And this necessitated implementation of risk mitigation strategies. And there was multiple risk mitigation strategies that were put in place. The first of which was the modification of the maintenance dosing approach. So starting with a lower starting dose, a lower starting maintenance dose, the addition of a dose individualization based on the concizumab plasma levels, as I mentioned, at 4 weeks after initiating concizumab prophylaxis, as well as some more detailed guidance on breakthrough bleed management. So rather than using standard approaches to both dosing and frequency, in this particular case, because it's inhibitor patients and bypassing agents, looking critically at minimally effective doses and being very thoughtful about both the dose and frequency to minimize risk of thrombosis. The Explorer 8 phase 3 trial for concizumab looked at individuals greater than 12 without inhibitors. Of course, this is not a currently licensed indication for concizumab, but this included 63 patients. For this study, the design was similar to the prior, though the observation period ranged from 24 to 32 weeks, followed by the 256 active week treatment. The dosing strategy was the same as were the primary outcome measures. And here we separate the hemophilia A cohort from the hemophilia B cohort. So in the first set of columns, you will see the summary for hemophilia A. So when you look at the number of patients on prior factor concentrate prophylaxis versus concizumab prophylaxis, in the hemophilia A group, we had 29 patients. In the hemophilia B group, we had 22 patients. When we look at the mean treated ABR, it was actually similar between the prior prophylaxis and concizumab groups. For hemophilia A, 2.2 versus 2.3. And for hemophilia B, perhaps a slight decrease from 2.1 with the prior prophylaxis to 1.4 on the concizumab prophylaxis. And similarly, you can see the mean treated bleeds as well as the ranges included in this table. So in general, the median ABRs maintained patients with hemophilia A or B who had been stable on their prior factor concentrate prophylaxis over the prior 56 weeks. So again, I would highlight a few things here. So certainly some differences between the approved population in terms of reduction of bleed rates and on-demand strategy versus having access to prophylaxis for inhibitor patients. Clearly both a clear statistical as well as clinically significant difference. although still technically under investigation in the non-inhibitor population, there isn't as much of a difference in the overall ABRs that were noted here. So perhaps for similar bleed control, the question is factor VIII concentrate, factor IX concentrate, IV therapies with certain frequencies of intravenous infusion versus daily subcutaneous therapy. There can be considerations from patients, caregivers in terms of administration burden for overall similar efficacy. And similar to, as I mentioned, with the marstacimab studies, for the concizumab studies, we also have elements that have not been captured well in the clinical studies. And these similarly include significant inflammatory illnesses, major surgery. And though I didn't mention it specifically for marstacimab, it's true for concizumab and marstacimab. Significant exploration in the female population or any data relative to lactation, pregnant females, et cetera. And then lastly, we'll just turn briefly to the Atlas open label extension study for fitusiran. This was the third non-factor therapy, rebalancing therapy on that initial table that is the antithrombin silencing RNA. In this open label extension study, males greater than 12 years of age with hemophilia A or B, with or without inhibitors, are being evaluated, looking primarily to characterize the long-term safety as well as tolerability of fitusiran, and then secondarily, of course, looking at long-term efficacy. There were a number of lead-in pivotal trials, including an inhibitor study, a prophylaxis study, and one more generically for hemophilia A and B patients that wouldn't have otherwise fit in one of the other studies that leveraged a different dosing strategy, namely 80 milligrams subcutaneously monthly. Similar to the concizumab study for the fitusiran trial, there were also challenges with thrombotic events and a voluntary pause in 2020. And then again, later in the clinical trial course, similarly led to some risk mitigation strategies that needed to be put in place to optimize fitusiran as a potential prophylactic agent. When we look at the annualized bleed rates for treated bleeds for those in the hemophilia A or B population with fitusiran, you can see the first graph here looks at the estimated ABR for individuals on bypassing agent prophylaxis with a mean ABR of just over 11, compared to those on the fitusiran dose-modified prophylaxis regimen, where we see an estimated mean ABR of 3.4, so a 70% reduction. Similarly, if we look to those individuals without inhibitors on clotting factor concentrate prophylaxis, the mean ABR was just about 6, and very similar actually for the fitusiran prophylaxis at the dose-modified regimen. So key takeaways for this section are that the therapeutic landscape for hemophilia is rapidly expanding, and we have many new novel products that have been recently approved for prophylaxis, as well as several that are ongoing in clinical trials. Both marstacimab and concizumab are well tolerated in the clinical trials, with no reports of additional thrombotic events after dose adjustments and bleed treatment risk mitigation strategies for concizumab specifically. Shared decision-making is critical when individualizing prophylaxis regimens to meet patient needs. As you've seen, consideration of both the bleed rates as well as physical activity, comorbidities really will play into good decision-making around optimizing prophylaxis for individuals.
Now Emily will be discussing how we prepare for rebalancing therapies using case presentations to highlight her points.
Thank you, Dr. Shapiro. I'm talking about how we're going to prepare for rebalancing therapies today. The benefits of replacement, as we just discussed, these products can be used in patients aged 12 years and older with hemophilia A and B with or without inhibitors. Marstacimab is approved for those without inhibitors, and concizumab is approved for folks with hemophilia A or B with inhibitors. The subcutaneous administration of rebalancing therapies may offer benefits for certain patients over IV factor replacement therapy and can be administered at home with a pre-filled, ready-to-use pen device. Marstezumab does not require weight-based dosing, and both drugs have an established efficacy and safety profile for their approved populations. Patient characteristics for rebalancing therapies that we need to consider. We need to align our selection of therapy with patient goals for treatment, carefully assess patients with hemophilia A or B, including those with inhibitors who may benefit from rebalancing agents, as well as consider the they're suitable for patients with moderate to severe hemophilia with recurrent bleeding episodes, and there are age restrictions on these therapies. In terms of treatment initiation and monitoring, we want to develop a structured plan for transitioning patients from traditional therapies to rebalancing agents, continue to track individualized annualized bleed rates, monitor joint health, as we often do in our comprehensive clinics, by using joint range of motion, functional assessments, bleeding rates, and imaging to assess long-term outcomes in patients who are prone to joint hemarthroses. We want to assess adherence to guidelines for the treatment of breakthrough bleeding events, as neither of these products are indicated for the treatment of bleeding, and assure that the dosing of those products is adequate for hemostatic control. Some of these agents require assessment of laboratory parameters. We need to create protocols for managing patients on rebalancing agents who require surgery or invasive procedures, and watch for signs of thromboembolic events. When we're talking about managing breakthrough bleeding on the rebalancing agents, we need to establish clear protocols for the management of breakthrough bleeding. For example, utilize the clotting factor concentrate and bypassing agent dosing guidance developed in the clinical trials and indicated in the package insert for each product because of the history of thrombotic adverse events. Replacement therapy or bypassing agent treatment may still be needed in some cases, but at adjusted doses, generally the lowest effective dose given at less frequent intervals, as determined by the clinician and patient response. We want to educate our patients on recognizing signs of breakthrough bleeding and when to seek medical attention. In terms of providing education and training to our patients and colleagues, we need to really think about providing comprehensive education to clinical staff on the mechanism of action, administration, and monitoring of rebalancing agents. This includes those in your clinic, as well as those who may be covering on call and in emergency settings for your patients. We need to train patients and caregivers on subcutaneous administration techniques for home treatment. These devices use novel pen technology and may be a different mechanism of administration for patients who've previously been using clotting factor concentrates or IV bypassing agents. We need to be clear with our patients on when laboratory monitoring is needed and the interval for that monitoring, and then provide clear instructions to patients and families on how to manage minor bleeds at home and when to escalate care. In terms of long-term follow-up, we need to plan and monitor for potential late onset adverse effects and assess sustained efficacy. That includes looking at patients' ABRs pre and post transition to a rebalancing agent therapy, adjust treatments as necessary for changes in weight or breakthrough bleeding rates, and consider participating in post-marketing surveillance programs to contribute to the growing body of evidence on these novel therapies. Now we're going to do a case study. Meet Luca. Luca is a 20-year-old male college student with severe hemophilia B and a factor IX inhibitor. His baseline factor IX level is less than 1%, and he developed his factor IX inhibitor at 17 months of age. His historical inhibitor peak was 58 Bethesda units, and unfortunately, he developed nephrotic syndrome during an ITI attempt, requiring discontinuation. He has a history of recurrent hemarthrosis, and his target joints include his right elbow and left ankle. Luca is currently using daily bypassing recombinant 7A for bleeding prevention. He has a central venous access device to facilitate the frequent IV infusions. His current ABR is 10.5, and he was hospitalized for an iliopsoas bleed last fall, requiring him to withdraw from his college term mid-semester. Luca's baseline labs are generally within normal limits. He has a normal hemoglobin and platelet count, and a acceptably prolonged PTT of 68 seconds. His liver and kidney function tests are within normal limits, and his nephrotic syndrome has since become aqueous. Luca's goals for treatment include reducing his infusion frequency to improve his overall quality of life. He'd like to decrease his annualized bleed rate to minimize his academic disruptions, and he'd really like to participate in social activities without fear of bleeding. How can Luca safely be transitioned to a rebalancing agent? Luca is eligible as somebody with hemophilia B and an inhibitor to try concizumab. One of the first things that we need to do is educate Luca about the agent, its mode of action, its administration, and guidelines, and potential risks and benefits. We will need to review with Luca the importance of communicating with the HTC regarding the treatment of breakthrough bleeding. He can use either recombinant factor 7A or, if appropriate, an APCC product on demand at a reduced dose and frequency, or the lowest possible dose that is effective while on concizumab. In terms of initiating therapy with concizumab, Luca should have a 12-hour washout from his last dose of recombinant factor 7A before initiating concizumab. His loading dose per package insert is 1 milligram per kilogram subcutaneously on day 1, followed by a once daily dose of 0.2 milligrams per kilogram beginning on day 2 until the individualization of maintenance dose at day 28. Luca will return to clinic after 4 weeks of concizumab treatment for lab testing. An FDA authorized test for the measurement of concizumab concentration in plasma is not currently available, but an interim laboratory developed test is being offered by the manufacturer until an FDA authorized test is available. Once that testing is complete, the goal is to individualize Luca's concizumab dose based on the results before completion of 8 weeks of therapy. In our case, Luca's concizumab level at 1 month was within therapeutic range, which is 200 to 4,000. And that was consistent with about 70% of patients in the clinical trials who did not require a dose adjustment. We also want to make sure that we educate Luca on what to do if he misses a dose. Patients who miss a dose during the initial 4-week period after starting concizumab should inform their healthcare provider and resume once daily dosing at the initial 0.2 milligram per kilogram dose level as soon as possible. If patients miss a dose after the initial 4-week period, there is slightly different guidance that is outlined in the package insert. If a patient has missed 1 dose, they should resume once daily treatment at the maintenance dose level. If they've missed 2 to 6 doses, they should resume treatment with a double dose of their prior maintenance dose, followed by once daily treatment at the maintenance dose level. And in the case of 7 or more missed doses, the provider should be contacted and a new loading dose should be considered. Long-term considerations include the impact on joint health and potential for improvement in target joint bleeds and slowing the progression of arthropathy. We want to monitor for efficacy and make sure that Luca has a good understanding of our breakthrough bleed management plan. Another thing to consider is, as Dr. Croteau mentioned, neither of the rebalancing agents currently on the market have much data surrounding major surgery. And so there is a recommendation that if Luca were to require major surgery, we would discontinue concizumab 4 days prior to the surgical date and resume 10 to 14 days after at the same maintenance dose. A reloading dose is not specifically outlined in this protocol. When Luca returns to your clinic 6 months later, he did not require any hospitalizations. He reported improvement in academic attendance and performance, as well as in excellent adherence to his scheduled daily maintenance doses. His ABR was reduced by nearly 84% to 2.4 from his baseline. He did not experience any thrombotic complications, and he had significant reduction in target joint bleeding in his first 6 months of treatment.
Excellent. Thank you so much, Emily, for that excellent summary and case review. I found that very helpful. A few additional takeaways from all of our sessions together. Rebalancing therapies can help address unmet needs for patients with hemophilia A or B. Currently, 2 FDA and EMA approved rebalancing therapies are available, with additional indications and therapies under investigation in phase 3 and earlier clinical trials. Comprehensive education on the mechanism of action, administration, and monitoring of these agents is really essential for our clinical teams as well as patients and their caregivers. So with that, I will move us into the question and answer portion of our session today. We already have several great questions in the Q&A, so please do keep them coming. Emily, perhaps on the heels of that excellent case presentation, and I'll have Dr. Shapiro and Ms. Bisson join me again if they would. On the heels of that great case presentation, I'm curious, how are you approaching your potential patient populations who fall within these broad eligibility of greater than 12 without inhibitors, A or B, greater than 12 with inhibitors, A and B? How are you approaching letting them know about these novel therapies and having the discussion about whether that could be a benefit in their prophylactic regimen?
When new products are made available, Stacy, we write a patient information letter, a notification about new products to all patients who fall into the category of applicability based upon what's in the package insert. So they have received information about these medications. Based upon that, some patients call us to talk to us about that particular medication and whether it might benefit their care, the particular issues that they're experiencing that they want to address. Otherwise, we look at specific vulnerable populations if we don't hear from patients that we think would really benefit from consideration of the use of that medication. So, for example, with concizumab, the factor IX deficient patients who are 12 and older who have inhibitors, we think are a very vulnerable population. They don't have adequate prophylaxis. So we will be discussing with this drug with them individually to determine their desire to utilize it and whether they think it's going to benefit their care.
I think that's an excellent first approach. Emily, anything that you would add in terms of certain types of patients that you think might benefit from these therapies, or how to approach the education, both for our English-speaking patients, our non-English-speaking patients, How do we help get the word out and help with the medical literacy here?
Sure. I think that I agree with much of what Dr. Shapiro shared. We have a slightly smaller practice here in New Hampshire, and so I have a fairly frequent contact with most of my patients and a pretty good handle on who is doing really well on their current therapy and who we're really struggling to control bleeds with. Um, and so I certainly am prioritizing those folks in our patient population who don't have optimum control, whether it's a venous access issue, whether it's an inhibitor issue. Certainly the hemophilia B with inhibitor population is so high risk and so in need of some of these newer agents. Um, but even some of our patients who are aging, who need a subcutaneous option and might have hemophilia B without inhibitors, they haven't had an available product to them. And we do have a number of patients whose veins are tired. You know, they've been doing infusions for a long time. And so, um, again, trying to think about where we can utilize these agents to fill an unmet need and care.
And
Is there
so
anything on your part, Stacy, that you do differently from your perspective?
I think we use a similar strategy. I think one, certainly patients I've already identified myself as having a gap in how effective their prophylaxis is. So those patients that still seem to be calling with breakthrough bleeds, despite our best attempts to tweak doses, tweak intervals, optimize agents, obviously rise to the top for me in terms of directed outreach. But I'm always surprised, even some patients that don't have overt bleeding or call in with overt bleeding, they often are interested in learning more about these novel therapies. And I learned this as we had our first non-factor replacement therapy come through. Many patients that had great veins, no issues that they ever reported with venous access, no bleeds, that I thought they've been doing this for so many years. They're going to stick with their therapy that's tried and true, but I'll just mention it. I was always surprised at how many were like, oh, that actually sounds interesting. And so when there is an avenue to reduce the burden, some families are able to appreciate the burden that they've been living under, where others might say, it might seem like a burden to others, but this is what we've been doing. We're going to keep going. So I have tried to eliminate some of my preconceived notions too about patients that I would otherwise have put in a bucket of seem to be doing well controlled, and making sure that I'm hitting everyone in terms of updates for medications and really having thoughtful discussions and shared decision making about their optimal prophylactic therapy. One question that was mentioned here, and I think we might have talked a bit about this amongst ourselves, can rebalancing therapies be used with patients with mild or moderate hemophilia? So I think as you heard in my section, I tried as I highlighted the study designs, the studies were actually in severe factor VIII deficiency and moderately severe, so less than or equal to 2% heme B, with or without inhibitors. Technically speaking, I will say that the label says nothing. Neither label says nothing about severity of hemophilia A or B, such that if you have a hemophilia A or B requiring prophylaxis, they're fair game from a label perspective. But I'm curious, Ms. Bisson, Dr. Shapiro, what do you think about the mild and moderate patients and putting them on these rebalancing therapies for prophylaxis?
I think it's a great question, and we've actually had an effort this past year to really work on our patients with moderate and mild deficiency and look at their bleeding episodes. Because with all of the work we've done in patients with severe disease, what we realized is we're leaving them behind, and they're less protected than the patients with severe disease who are getting more advanced therapies. So we made a big effort to address this and talk to all of these patients, especially the ones that we thought were at higher risk, and also ask them about what is it in life that they're not doing that they'd really like to do because of the fear of, I might have a bleeding episode, which is really very disruptive. So I think that group of patients would benefit from the same discussion. with these novel agents to say, are the agents you're using now, does this meet your needs? Is it a burden to you to use this agent, or do you want to consider something different?
Would you agree with that, Emily? I mean, how do you think about sort of these novel therapies, the risks and benefits compared to other non-factor therapies or compared to other therapies that we already have in our armamentarium?
Yeah, sure. So, I mean, I think that I agree. We're doing something similar to Dr. Shapiro in really aggressively trying to knock down bleed rates, and we have been quite successful in the severe non-inhibitor population, I think, in doing that. I think the new rebalancing agents offer an opportunity for folks with inhibitors, specifically factor 9 inhibitors, to achieve that goal, but also for some of our mild and moderate patients. When I have conversations with these individuals in clinic, I often have to sort of remind them that we've really moved the goalposts in terms of our willingness to tolerate breakthrough bleeding. In some of our older patients, that's often an interesting conversation because they say to me, I have mild hemophilia. Um, I don't need prophylaxis. That's for the folks with severe disease. And then I look at their bleed history and I say, well, you've had 3 significant bleed events in the
Yeah.
past year. And I have patients with severe hemophilia who haven't had any, because they're on prophylactic therapies that work for them. So I think sometimes having that conversation over time, a number of times, and trying to meet them where they're at. But I would not necessarily rule out using a rebalancing agent in somebody who's having a lot of bleeding. I think the challenge, of course, is going to be to um, select the appropriate product for the patient, and then convince insurance to cover said product. But I think that it's becoming easier as we're, driving to zero bleeds, to make the case that everybody deserves access to treatment that matches their bleeding phenotype and bleeding presentation.
And again, as you both have highlighted, in a nice stepwise way. So I think for those mild or moderate individuals who are already on prophylaxis, there's a great rationale for continuation of prophylaxis and thinking about leveraging one of these agents in a safe and thoughtful way as a continuation of their prophylaxis. The addition of prophylactic therapy or the expansion of prophylactic therapy to new patients and things like that obviously warrants additional careful thought and consideration, especially as we have easier to administer therapies and what have you, which does bring us into this sort of interesting question about monitoring. So of course, with factor 8 and 9 concentrates, myself in particular, loved looking at levels and developing PK profiles, and there wasn't anything we couldn't measure. But for these non-factor therapies, as we ushered in first emicizumab as a factor 8 mimetic, now as we're ushering in these TFPI inhibitors, what are the obligatory laboratory monitorings, or what are the possible laboratory monitorings that you may be thinking about for your respective practices?
And actually, there's a question in the question box about what can we speak to our experience about ordering the concizumab level from Novo Nordisk. So my experience with that has been on the study, so it was very easy because it was part of the study protocol. And I would recommend that you speak to your local MSL from Novo, who will tell you about the mechanism that they have set up, because we had ours come speak to us for how to obtain these levels. And they've tried to make it as absolutely easy as possible to get these levels with couriers, et cetera, and sending it to the laboratory for you and getting it back in a timely manner. So what's interesting is in some of the information that's come out in the package insert for concizumab, and what we did on the study was we did monitor levels throughout the study. Obviously, at the 4-week mark, we're monitoring levels to make sure they're in the therapeutic range, not too high, not too low. but you might want to continue to monitor levels at some other time points for patients, especially if they're experiencing more bleeds than you might expect. You want to make sure that they're not running a level below 200, which if their initial 4-week level was okay, but now they're lower, maybe they've gained weight, maybe they're, an adolescent, you might monitor a level, and you can do that through this system.
Yeah, and I think as Emily pointed out, one of the challenges, of course, is that there is not presently an FDA-approved concizumab level, but certainly something that they are working on, I'm sure, that would make it more broadly available, easier to obtain and access. Though, as you said, the company is working very hard to reduce that barrier for sure.
Mhm.
Believe it or not, go ahead, Dr. Shapiro, as a
Well,
final thought.
I think there's one nice important question here. It says, how do you prepare a patient on a rebalancing agent planning a vacation away from your center if they require an ER visit for the management of a major breakthrough bleed?
I think these are great questions, and I will be brief only because we're at the top of the hour. And I think similarly, some great questions about what if they roll into the emergency room with a significant inflammatory illness and require hospitalization? What if they require major surgery, for example? So I think good communication always has to be number one. So regardless of where you are in the globe, I always tell and remind my patients, caregivers, we are available to you 24/7. So please reach out and involve us in decision-making and help put us direct in contact with the doctors taking care of you at bedside, because there is no, supplement for the experience and the bleeding disorder care that we provide, especially for these poor ER physicians, right, who never see hemophilia, let alone some of these novel therapies. And I think exactly what happens in those moments in terms of holding medications, continue medications, may vary a little bit, whether you're on a daily concizumab versus if you just took your marstazumab yesterday and it's a whole nother week before the next dose is due. And also the location, the severity of bleeding, whether or not you have an inhibitor. And I would encourage everyone, as you're putting your patients on these novel therapies, to have these discussions up front. What is the expected factor 8 or factor 9 or bypassing agent dose? What is the anticipated frequency for minor, moderate, major bleeds? And you, of course, will have the ability to leverage in the clinical moment exactly how you're going to strategize that, but to at least put some general guidelines so that patients are aware, it's documented in the medical record and things that they have access to, so that there's some anticipation of how to manage these folks when things get critical, and communication and timeliness is really essential.
To add to that, Stacy, we provide patients with travel letters with our number and the recommendations, and also like an emergency wallet card with dosing. People always forget something. Hopefully,
And we have them take, a photo of their letter to be sure it's digital on their phone.
Yes,
In case of emergency opportunities to add some of those details. So we have digital hard copy compliments. I think all of those are really excellent suggestions.
exactly.
So we do want to know a little bit. Hopefully you've learned something in the last hour and enjoyed joining us. Which of the following is potentially a unique benefit of rebalancing therapies for patients with hemophilia? Application to patients with hemophilia A or B, weight-based dosing, amelioration of joint damage, or use in pediatric patients less than 12 years of age. Excellent. Absolutely correct. Application for patients with hemophilia A or B. Marstazumab and concizumab directly target which of the following anticoagulant proteins? Activated protein C, antithrombin, activated factor 11, tissue factor pathway inhibitor. Terrific, spot on. Tissue factor pathway inhibitor is the correct answer. And lastly, what is the key consideration when transitioning patients from factor replacement to rebalancing therapies? Cessation of all other hemophilia treatments, establishing appropriate washout periods, increasing the dose of factor concentrates, switching to on-demand treatment only. Excellent. Establishing appropriate washout periods. So I want to give a special thank you to my co-presenters for their time and insights on this important topic. We hope that you found this educational webinar useful to you in your clinical practice. As a reminder, all of the ISTH webinar recordings are available at the ISTH Academy for your reference, and you will find a copy of the recording for this presentation there as well. Thank you so much and have a wonderful rest of your day.